So since we have a group now of people, many of whom who have been together for most of or the whole workshop, maybe we can use the opportunity to try to draw together some of the themes that were coming up, to see what common threads we had. So Rachel and I thought we might start this off, the discussion, with an attempt at doing that. And you can then discuss whether you like it or not. So because in the course of the workshop, we've been exposed to a wealth of historical material, and in some cases, quite heterogeneous cases. And we had the original title of the workshop, Technology and the Patient Consumer. And this original title doesn't even cover all of it. So not everything was actually about the patient consumer, but somehow all the contributions belong together. So they speak, we find, to a common theme or a number of common themes in the plural. And this is why we have the suggestion of kind of retrospectively reframing the topic of patient consumer to be more inclusive. And we can come up with a title such as patients, consumers, citizens. We can add users, activists, maybe. So all these agents, patients, consumers, citizens, users, activists, and then subtitle, agency and new technologies, maybe in medicine. And because that covers 2 points that all presentations have in common. And number one is technology. So it's about the introduction and the use of new technologies in medicine, or even outside of medicine in a narrow sense, or medicine in a broader sense, dialysis, or suntan lotions, or t-shirts. Or we have, I think we agree that we would call all of these things technologies. So that's one of the commonalities we have. And in most presentations, there is a particular emphasis on agency. So that's point number 2, agency in some form or other. So the technology can be the object of agency. For example, the technology can be used, it can be consumed, or people want to get access to it. But some of the technologies that we were discussing were more about enabling agency. For example, the internet, or social media, or the press, other media too. So, of course, these technologies not only enable agency, they can also limit agency. In other words, they shape agency in particular ways. We have seen some examples of that. So how agency is shaped, that can depend on the technology itself. So the different media have different effects on that. So it can structure, the technology can structure agency, can enable or inhibit agency. And when we speak about this point, agency, we also can and probably should unpack what we mean by this term agency. I mean, most obvious, we've talked a lot about that, especially at the beginning, agency can be choice. In the case of the consumer's agency is choice. But there are other ways of exerting agency that have come up in our discussions. So this example of choice as agency leads us to another important aspect that has been also brought up in the presentation, and that is that agency depends very much on specific contexts. So it depends on technologies, but it depends on other things than the technologies themselves too. For example, it depends on who is attributed agency in that specific context, or who is not attributed agency. So, and that depends often on factors like race, class, gender, but it also depends on the medical condition, the diagnosis in the case of patients. This shows us that having choices that being a consumer, having an influence, reflects a certain level of privilege. So that's an important point when we speak about consumerism that we can add. But then we should also consider who it is that we are speaking about. So that's the first part of this new retrospective title. So if we broaden the scope, we can clearly go beyond the consumer, and we can also go beyond the patient. It's not just consumer patient. We can include all kinds of different roles of the subjects of agency: consumer, patient, informant, data source, and so on. And we can add an element of dynamics. So we can look at how these roles can shift. For example, as Shara has done it, from consumer to patient to informant. And we can make the variability, the instability of the roles of those who can attribute agency part of the discussion. And if we do this, and if we look at the multiple roles or multiple identities, this will make it possible to also better see what a consumer is. It will help us to better define what we think is characteristic of a consumer. So that's the category, of course, that we had as our starting point. And we can describe what is associated with a consumer role, for example, choice, or the patient role, for example, passivity, but also protection as a patient that came up too. So if we open up the topic, we can discuss the different forms of agencies, the different distributions of agency for different technology and for different contexts. So we can discuss around the questions of agency, the role of technology, the various agents or actors involved. And this is how we can end up with this new retrospective title: patients, consumers, citizens, users, activists. I'm not sure where to end this list, actually. And then subtitle: agency and new technologies in medicine. So I'm sure that the people who are here have different views on these suggestions. So you will be looking at them from your specific perspective, also on the background of your own case studies or on the background of your own experience as doctors, as patients, as consumers, or as historians. So my starting point for the discussion would be, what do you think? Would such a framing of the topic work? Is it maybe too open? Or is it still too narrow? Should we go further? Or does it make any sense at all? So that's what I would offer as a starting point for the final discussion. Rachel, would you have anything that you would like to add?
I don't think so, because I think that was kind of capacious enough that I don't want to necessarily add to it. So maybe we can just start there and see what people think. We probably talk a little bit about the utility of the term patient consumer. Is there sort of any, does it add any value to how we're thinking about patients? I'm thinking back to that slide, the sort of tendency to define patient consumers in opposition to patients. Probably when a lot of you applied for the call for papers, probably we're thinking, you had a story about patients and technologies, but I don't know how much the consumption angle was already a part of the story, sort of so defined. Sorry, that was inarticulate, but I think it's the time of day. Sorry, I'll let other people speak.
Samuel.
Yes, thank you. And I'm sorry I missed out some of the talks. I have been in and out of a hospital for the last 2 days as a patient. I guess I surely didn't feel as a consumer, but I did feel like a patient. But I attended enough sessions to get a sense of all kind of the trust of what people were presenting. I want to go back to this issue of a consumer and contrast it to the issue of a customer. So some of the attributions made to consumers really are possibly more appropriate to a customer than a consumer. So we consume food, we consume healthcare, and we need to be protected, and we need to, do no harm kind of things. And we have the EPA and consumer protection agencies and things like that. But the idea of consumers as people having agency is possibly more linked to the idea of a customer who has choice and thus can take their business elsewhere, as they say. So a consumer is more somebody to be protected. I'm not sure how much agency they have. So it's not a challenge to what you said, Thomas. I love the trust of the focus on agency. It's just want to make sure that our language is consistent.
Yeah, what is meant by agency includes lack of agency. So it's just to include the point of agency, not or a little agency or none, as one of the things that needs to be discussed if we speak about this topic. Thank you. We'll go through the speakers list. Elizabeth.
So I actually despise consumer because it doesn't have a moral relationship. And I really don't like the word agency because it's jargon. And I have a real problem with jargon, and because I think it's very exclusionary. And I think when I look at what went on this week or the last 2 days, when I hear about the x-rays, that was about abuse of consumers, the dental x-rays. Because I know what happens is, they lose their teeth, they get burns, they get disfiguration, but you don't hear about it. And so to sort of, the consumer having agency would be true. It would be like in the last talk when we were talking about laparoscopies, because that was pushed forward, but it was also abused. And so I think the patient, I was just listening to what you said. It's not that you can go elsewhere. You can go elsewhere, but the truth is unless you have the education and the trust in your doctor, I'll go back to the vaccines. The way to get people to take vaccines who are hesitant is to ask them to talk to their church, to talk to their doctors, to talk to people they trust, the nurse practitioners or wherever it is. So I personally think that you are, the title of customer, patient as customer, initially, I didn't even want to come to them. When Rosenberg asked me, yeah, so no, sorry, as a consumer, to me it's the same. I understand for you it's not, but for me it's the same. And so it's like when I say something like your hand is superior to your leg, I mean it's above. I don't mean it's better. But the truth is so if you want to include more people who aren't specialists like you are, who actually are very careful about how you use terminology and jargon, you have to make it more accessible and interesting to us. So I was just came back down from palliative care, and I was telling them about this, and I was telling them how interesting it was and how, it was really opening my eyes and how I was talking to a few of the doctors up there. That's why I got a little bit delayed. And I was just saying, you really would be nice if you could come and hear them next year, because it opens your mind. And what I feel is both consumer and agency, like you could have it as your subtitle, but to me, it puts me off, and it puts off people who aren't experts like you.
Thank you. Yes, I can see that risk very much. So with a moral relationship, yes, that's because if you're a patient, you have a certain kind of protection that you don't have if you're not a patient. We heard about that. So that's a very important point that needs to be considered. About agency, yeah, what would you use? Then the possibility of acting, the possibility. What would be a good term to describe this dimension?
Well, I would suggest you're the best people to say it because you spend all your time thinking about these things, whereas I don't. I'm just reacting, and so I can think about it. But I would suggest you ask the people here, because what if I asked you, what does agency mean? Like if I ask you, what does agency mean?
It's the possibility to act, to have an effect.
To say that it's a joint decision is a very different thing. To say it's to me, it's like I believe very strongly that you must have buy-in by the patient. I believe that you must you must be able to trust the, and we get betrayed by patients as much as we betray patients. So it's not like it's because we're all human beings and we all make mistakes, and the mistakes we make are horrendous. Like there was a beautiful review in the literature about 20 years ago, and they were talking about doctors who made huge mistakes and the patients died or suffered tremendously afterwards. And every single one of those doctors said, well, I woke up in the morning and I had an egg for breakfast, and they would remember every second of that day. So it's not, what I feel is the future is in us, people with your knowledge base, which is different than my knowledge base, working with people like me. And so all I'm saying is, I'm not saying it's marketing, I'm just saying is I don't think you're selling yourselves well. And I think you should. Like, I think you are a bright way forward. And it's, when I listen to you speaking, you are very articulate, you understand what you're saying, you are engaging me. And I am not the easiest person in the world to engage. I'm so tired and so overwhelmed and so burnt out. So you have this great gift of looking at things. So all I'm saying is, please don't sell yourself short.
Thank you. That's very important, a very important point. But it still leaves the question open, what can we use in terms of language to describe what we want to describe? But thanks, Vivian.
Yeah, sorry, I totally take this point of, finding ways to speak across disciplines and across spheres. I don't have a good suggestion for an alternate word to agency. And so I'm actually going to offer what might be more jargon just to share, what I was thinking, Thomas, as you were speaking about centering agency, which is, longstanding conversations about technological determinism. And that, I really like I like, using agency as a way to frame many of the things we talked about. And I think it's really important, especially when I think back to my story, to think about the agency that's being attributed to the technologies themselves. So not so much that we maybe need to get wrapped up in a historiographical argument about whether technological determinism is helpful as an analytic frame, but what always strikes me as so important is seeing where the actors themselves are attributing agency, because I feel like there's sort of a balance of agency and a balance of trust, and that the more agency that's being given to the technology, the less agency patients and even practitioners have. So I just wanted to throw that out there as I think an important possible agent that we don't want to forget, which is, the machines themselves. And I mean, I know that I think it is more prominent in my own work because I'm thinking of machines. And so for some of the rest of us, I mean, maybe we don't think about, t-shirts having agency, or I don't know. So, I think that's just something that we can all think about with our case studies. And I'll keep thinking about whether there's another word that we might be able to use.
Yeah, I agree. A lot of the cases have talked about that. Let's call it the effect of technologies. That it makes a difference what technology exactly you use, and so all that we use this word agency for.
Could I just say something? Why do you need it there? Like, if you had patience and technology, like, what, to me, that you can do what you want. It can be good and bad. Like, I'm just saying, it's like, why do you want something extra? Whereas patience and technology, I'd love. And you'd still give the same talks. And you might get more of me. Not me personally, I mean doctors. Because inherent in the words like agency is it's going to be attack on us. I'm just saying, it's like, if it's sort of like if I wrote to you and I said it's going to be about students' agency or students, it suggests that the students, I understand in your case you wouldn't see it as a bad thing because it's the sort of people you are, but a lot of people see it as being judged, as being like, when you do, I'm just saying, if you look at it, that the doctors will come out bad, and we get a lot of being analyzed as bad. Like everything in the hospital is our fault. Everything that's bad is our fault. So I would say you don't need anything other than what you're doing.
Okay, that's a possibility. Okay, I have as next discussant Grazia.
Yes, I was just thinking about, well, I don't have any answer, as you know, for alternative terms to patients and consumers, but I was thinking, I know that this definition of patient consumers comes from a particular context, so the possibility for patients to choose in the context of the American capitalist society. But still, if I look at the issue of the patient consumer from a more abstract point of view, almost from a historical point of view, I can't help but thinking about who, if we think that consuming means choice, who would choose to be a patient? And as a patient, I would have never chosen to be a patient. And so is it really possible to combine the two things, choice and being a patient? And another thing I was thinking about yesterday, about the people, the activists I study, so breast cancer action activists, they referred to themselves as consumers or as activists, depending on the situation, depending on the person they were talking to. Sometimes, for example, when they decided to buy some shares of Avon in order to force the company to take some toxic ingredients out of their products, they would refer to themselves as consumers, whereas in different contexts, in more radical contexts, they would refer to consumer advocates, almost in a negative way. So maybe, you can be a patient, a consumer, an activist, all at the same time. And maybe the real agency is this, to play with multiple identities, because after all, as patients are subaltern subjects, especially in a capitalist economy, in a capitalist society. And so, yeah, playing with these multiple identities probably helps patients to navigate, to better navigate this state of subalternity. And yeah, these are just my random thoughts.
Oh, they were not random. So it's really about that the different roles are not static, not a given, that there's an active appropriation or rejection of them, and that the people who take these roles have I'm trying not to avoid the word agency, have room to act on that, I also want to avoid the word choice here. So, but yeah, it's more the dynamic element that you're emphasizing. Absolutely, yeah. Thank you. Shara.
Yeah, I hear what you're saying, Elizabeth, and by the time the titles roll around, the publisher's going to have a big hand in what people say anyway. So patience and technology, I think, does provide an umbrella. I think the thing that's really important to me, and I've heard in a lot of the papers, and I know this goes back to Langdon Winter, and I know Rick cited him as well, that technology is not neutral. And so I think this is like the core to all of this. And it's hard to pound that message into people, because so it's just easier to accept it and to accept that it's progress and what it means. And so that idea, I think, does need to come across in an introduction, or, you know, in talking to folks, and as we try to bridge different disciplines, about not taking the problems for granted, because there's so much built into the technologies, from race to gender to access to class. And, you know, all of us have spent years and years and years studying this stuff. And so it's hard to squeeze all that in sometimes to convey that to practitioners. I do have the privilege of teaching a class that I created called Medical Devices and Innovation. And it's a class that's taught through the history department, but it's almost, as you can imagine, all scientists and a lot of engineers. I think there's usually only 2 or 3 humanities students in the class. And the thing that I try to do is to give them analytical tools and case studies. And so, you know, I have the luxury of a semester to do that. But to me, some of this more theoretical stuff is totally necessary, because it's the lens, it's the way in to start seeing things differently, whether it's surgery or whether it's the tools or whether it's mammography, and students aren't taught to do that in their science classes. They're really great technicians, but they're not so good at seeing the big picture. And yes, we need to speak your language, but I think we're saying too, you need to speak some of our language as well. And so this translation has to happen, and it's hard. It is so hard. And I feel like I knock my head against the wall a lot. And I'm sure you're like, as well, you're like, okay, why can't they just talk to us in a normal way? But some of the things we're talking about are really quite complex. And so we need some patience too. So I think it is having compassion for one another just seems really important in this, to just improve things, because I think in the end, we all do want it to be better. I mean, I think this is the thing, we see so much room for improvement. How can we do this better? Because it's not that we want to tear down science and medicine, but man, with a few little tweaks and things here and there, it seems like we could have better outcomes all around.
I'm not disagreeing. So one of the things that I had asked for after the first course is because we were talking about all this AI stuff. I had a real serious problem. No one was talking about ethics. I understand how AI, as Dr. Rosenberg says, will help us, you know, diagnose things on X-rays or pathology or whatever. I just really, really dread it. I mean, I really dread it. I just feel that we're going to be implementing so many things that are actually so against human beings. And so like, I would love, like, so what I'm saying is instead of having a patient as consumer, couldn't you talk about technology and the patient, good and bad? Like, couldn't you just talk, or risks, like technology and the patient, risks and advantages? Like, I'm not saying to talk about, I'm just saying it's like, how do you know, I have a lot of political activists as my friends, okay? So words like agency and all of that, I hear, but all I'm trying to say, and I don't want to dominate it, so I'll stop after this. All I'm saying is most jargon used in hospitals are by managers to control us, to conform us, to stop dealing with, this is a patient and they're different from the others. All they want to do is measure and show turnaround time is better, things are cheaper, and they're not understanding that by eliminating the human side, our compassion, our creativity, or the fact that we recognize you and Grazia, you may have given the same session, but you're different people. And you should deal with both of you differently, as opposed to we must do the same thing. So most of the jargon, nurses, doctors, most of the people see it as being anti-us doing what we want. That's all I'm saying. So it's just giving you a view into our side of things. And I think you've got too many valuable things to say that you shouldn't, at least with the title. You know, like what you put inside it, I don't mind. I'm just talking about the title. It should be something that, I mean, your course that you were talking about, that should have been given to medical students. You know what I mean? Like, I just listen to what you're saying, and I think like that's a tragedy. That's an absolute tragedy, because every single one of us should be looking at that. And that's all I'm saying. I had nothing wrong with your title, by the way, in your course. But either way, I'll be back next year, regardless of what you call it.
Thank you very much. Antoine.
Yes, thank you. I just have a few disjointed thoughts, mostly as a way to respond to Elisabeth's suggestions. I mean, I think it's important for us to think about the right language and to avoid jargon. I think even when we speak to one another and write for one another within the field, we should try to go beyond a jargon. I would say as far as the particular words we've discussed, I'm happy to, I wouldn't be sorry to see agency go away, perhaps for slightly different reasons. Not, I mean, I see the word a lot because I'm in the field, perhaps also because the concepts has been used so much that it doesn't really refer to any very specific theory or tool. Anyway, so that might be my sense of I wouldn't be sorry to see agency go. I mean, I guess choice is something slightly different, especially if you want to talk about the agency of non-humans and machines, then choice is no longer perhaps an appropriate word, but it might be a placeholder in that respect if we do need the word in the title. I have different feelings about the word consumer, perhaps, and like Elizabeth, I hate the word, but perhaps I hate the word because somehow I hate the thing or the idea that goes with it, and I hate the idea perhaps that it would be, defining or structuring the patient experience, even though patient is also a word I don't really like for that reason. But so I find the word also for that reason disgraceful, perhaps. But to my sense is that it is still a reality, and so it does, however, I think capture what we talked about. And I mean, I don't know how other folks feel about the word itself, consumer, but I would suspect most of us just probably don't really quite like the idea that a patient should be defined as or is defined as or put in the position of a consumer by the structure of our medical system. But it seems to me to be a reality, and that's the reality we address and we critique. So I don't know, perhaps that word does need to be in there. I don't know. But then and final point perhaps is, I mean, I definitely think we should meet the challenge that Elizabeth presents for us and think about, perhaps ways to reach out to broader audiences than just the field. But then perhaps the conversation should be what audience exactly. I mean, there are many different groups, but thinking just about speaking to the field is what we perhaps our default position. But then, just the general public is also something very elusive. So, what are perhaps specifically the other groups we would like to reach out to is perhaps the first question we should ask if we're going to think about what language we should be using. So.
I mean, for the purposes of this workshop, consumer was used kind of not of what we think. It's more an actor's category. So it's out there, it's being used, and it's being used in different ways, actually, as Summer has also shown us. So the consumer also, for some people, it has a very positive meaning because it empowers. It's the meaning of empowerment. I know that it also has very much the negative meaning, also for me, if I see it, and for most people, I guess, we first think of something, no, we don't want that. We want a patient to be a patient and to be protected. We do not want to be a consumer like in any other situation where we buy a car. We don't want to buy a surgery like we buy a car. But it also has, as a word, as a term, it has different layers of meaning for different people. And it was meant as a focus, not in order to claim that this is the right way to go. It was meant as a focus to discuss about it controversially and to understand what's going on. It's too bad if that use of it then has the effect that people are not interested. But that's very good to know, Elizabeth, that this, because one would not necessarily think that just the use of the word consumer would keep people away. Because it could also be read as being a criticism of the patient as consumer. So people who also see it critically would then rather join in instead of staying away.
What I would say about what you just said there actually rang a bell with me. and I realized this would be the divide we have. You use words like agency and consumer as very positive or negative things, and you know with your subtext, and you know with the way you're balancing it what it means. What I'm saying is if you went to 100 people who were not academics like you are, which, you know, as I said, you have a very different knowledge base, I guarantee you very few people would see it as a positive thing.
No, we wouldn't either. And as a direct reaction, most of us wouldn't either, but we would see it as a term that's being used by others, and a concept, not only a term, actually an idea that's being used, and we would then question that idea, and we would try to find out where does it come from? How can we see it historically? Or we would look and try to unpack it, like Summer did. So what does it actually mean for different people? But I can also see that it's a signal. It's a signal word. If it appears in the title of a workshop, it signals something to different people, and it seems to signal something that we didn't want to signal. So that's why it's very good that you're here and you can tell us.
I mean, a patient, we see them as partners. We don't see them as users. You know what I mean?
Yeah,
like, and so to me, a consumer is a user. No, that sounds awful, but you know what I mean? It's a very, but you know, this could be just me.
Yeah, but there are not that many people from the medical world who have joined. Maybe you are right in pointing out that there's something about titles that could be different. And then, I mean, one could try to choose a title that is less or has a different emotional connotation, a better one, and then people would come, and then we could talk about it. But if it already deters people from coming, then maybe, well, I agree, then we should really think of, let's say, a more neutral title.
Anyway, I shall do my best to recruit people next year.
Yeah. So anyone else? Yes, Summer. I was seeing that you were at the cusp of raising your hand.
I put in a comment as we agreed.
Oh yeah, right.
So I see the sensitivity of people toward the word consumer. I see the sensitivity of people toward agency, and I actually agree with it 100%. And again, this is an audience made up of historians, so I'm not the one to tell them how to analyze this, but in my sense, again, from where I sit, is that some of these horrible stories like the x-rays and some of the early things that we saw happen, they happened because the patient was reduced to a disease, an embodied disease, basically. And I hope I have a sense that we are not there. We're actually doing a bit better in the 21st century. So a title that would indicate that would be helpful, and especially a title that shows how technologies are changing the balance of power. I know Vivian mentioned power, autonomy, interdependence in the chat, but there's the lines are being redrawn. So the internet and the web have given empowered consumers. Patients can check on their disease before going to meet their doctor. That's new, and new technologies are changing the old relations. So maybe a title about empowering, if you want to keep patient consumer, empowering the patient consumer would be the first part of a title, or how the relations between patients and doctors are changing. I mean, you can emphasize the dynamic, what's happening now, rather than, I mean, these are my half-baked thoughts.
Thank you. But I think power is also problematic. So it's very negatively connotated. But yeah, thanks also, Vivian, for the what you wrote in the chat: independence, autonomy, power.
Because
Yes, sorry.
Sorry, I beg your pardon. What I was trying to say is patient as consumer makes it look like being a consumer is like they're going. When I look at almost all your talks, all of your talks were very critical in many ways of the limitations of technology. And if you look at Shara, what she was essentially saying is, look, technology can be a betrayal of the patient. You know, like it's. I mean, and the thing is ye are much fairer than the knowledge than the title is suggesting. Do you understand? Like ye are being critical, and maybe you're doing a critical analysis. You're not swayed by your own basic beliefs. Well, everybody's a bit swayed, but you know, like you're trying to do as much as possible a fair analysis. You know, I mean, you're not saying the patient is powerful. You're not saying they're not powerful. What comes out after your analysis is your answer, whereas your title shouldn't give you. They should understand it's an analytical approach. It's not a foregone conclusion. Do you know what I mean? Like it's that's what makes it interesting. You know, like if it was a patient and technology, good or bad, I'm not saying you're going to put something as simple or silly as that, or risks and benefits. You know what I mean? Like it's technology. Actually, I'd put technology in the patient, not patient technology, because technology is the big thing, and the patient, whether we like it or not, is secondary. But risks and benefits, because then I would think, well, I'm not saying to go with that one, but you know what I mean? Is like what you do is much more complex than your title is saying. That's all I'm saying. Do you know what I mean?
Yeah. There are lots of risk and benefit titles. So that's a big risk to use that kind of title, because then nobody would see it's something new. But anyways, we're not talking a lot about language, though actually while we're talking about language, we're also talking about the content. So we're actually, it's for us has been a means of also negotiating what has been going on at the workshop, and also between different audiences. That's also quite interesting. Is there anything else that anyone wants to add? Anything that struck you or strikes you, or that you would like to emphasize?
I started to write a comment, and so I can just kind of say what I was thinking, which is for me, patient consumer is more context, as I think Grazia suggested. And so actually, I would like to see that kind of not disappear, but kind of recede into the background a little bit. The other thing I was thinking is that so many of these stories and the focus on technologies and patients are ways of examining what happens directly outside of medicine, and sometimes in response to. So, you know, whether it's different communities that coalesce around risk or side effects, or because they're demanding access to a certain kind of technology, like it, again, it's kind of methodological. It provides insight into other kinds of stories potentially. And that doesn't lead us to a title necessarily, but like I thought that might be worth emphasizing again towards the end. And then I started to type out a third thought, but all I have is also, and then just my blinking cursor. So I, I forget what it was, but if it occurs to me, I don't know. I think this is why I've always been attracted to studying patients, studying technology, is because it gets us potentially away from, you know, the types of stories that like Rick alluded to, that for many decades, people have been writing within the history of medicine. And I think that that's a really good way to go. So I'll let you know if I think of my third thought.
Well, patience is another of these terms that we want to question, or want to frame, or we want to contextualize by other roles that people can have, because we were not all talking about patients all the time. So in some of the cases, there were no patients, or sometimes there were patients that became something else. And yeah, but it's the same thing with consumer. But yeah, but I totally agree with what you said, Rachel. That's a very important aspect. Great. So this was a very nice experience, very interesting experience in many ways, in particular in terms of learning about the different examples that you gave and the kind of phenomena, the kind of trends, the kind of that you observed, the kind of questions that you were asking. So I enjoyed it a lot, and I think a lot of other people did too who were here. So thanks to everybody for first of all, to all the speakers. Thanks for joining. Thanks for making the effort of sending us the material and of volunteering in the first place. Thank you also, I should not forget, Rachel, thanks for helping to, I mean, you did most of the work, I have to admit. And so thank you for that, for also in choosing the topics and everything. Thanks for that. Then thank you to the chairs. I don't know if many of them are still here. I see Elizabeth and Summer. So thanks to you guys too, and to everybody who came to discuss. So I guess.
Thank you, Thomas. I think we have one more comment from Antoine if he.
Yes, Antoine.
Well, I didn't realize our time was out, but then I do have one question, which is how does the conversation continue beyond today, or do we keep in touch by email? Is that what
yes.
we
So
envision?
we don't know what we do as a next step yet. If we want to, in the past, all of the workshops it was clear that we were not publishing anything. This time we might. So because it's, I think, or we think we have a focus, and we might think about how, which of the different contributions fit with this focus. So if we can come up with something that binds them all together, and so we would then in the next step ask, though, if we decide to go ahead with that plan, with that idea, we would get in touch with you and ask you if you would like to contribute. If your topic is, if we think that your topic would be a contribution to the general theme of for example, of a collected volume or of a special issue of a journal, which are quite different because of the size. So special issue, you can have maybe 4 contributions, in the collected volumes it's more. So we are as yet undecided, but we have your email addresses, and our decision will really depend on how we think we can put it together and how the different topics would fit, how we could make it something that is convincing as a contribution, as something new also on the history of, now question is what, the consumer, patient, user. Yeah, so thanks for asking.
And presumably there'll be another conference next year, although focused on, yeah.
So that's a good question too, thank you. So we've had 5 of these. We also still have to decide if we do it really every year. Maybe we will jump a year and do it in 2 years. Possible topics, there are lots of them. One of them that is kind of, because of the background of COVID, is technologies in epidemics, so masks. Of course, that's the first thing that comes to mind. Tests and things like that. That would be very timely and might be interesting. So that could be something. There's also artificial intelligence. It has been on the list for quite a while. There's global health that has been on our list of possible topics also for a while. So we will see if we will try to organize one next year or the year after, and about which topic. But thanks for bringing this up, Rachel.